From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello, and welcome to this author interview from the JAMA Network. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology, and today we're going to look at the social determinants of health and some perceived barriers to care in diabetic retinopathy screening or monitoring. And joining me is Dr. Sophia Wang. Dr. Wang is an assistant professor in the Department of Ophthalmology at Stanford University. Sophia, thank you so much for joining us.
Thank you so much, Neil, for having me. I'm pleased and honored to be here.
Maybe we could start with a little background. I know from previous studies by the NHANES, the National Health and Nutrition Examination Survey, that we've always bandied about thinking maybe 50% of adults at least who have diabetes don't get an exam of their retina each year. What were some of the perceived barriers before you did your study that may have limited that to over half of our patients with diabetes maybe not getting an eye exam? What were some of the perceived barriers before you went ahead and did this?
Right. I mean, it is a shocking number, only 50 to 60% of patients with diabetes having their annual eye exams. And there have been studies that have previously examined some factors associated with those reduced screening rates. They might include younger age, minority, racial, or ethnic group members, lower levels of income or education, neighborhood deprivation, unfavorable housing conditions. Some of these factors were shown in larger studies, and some of them have been in relatively smaller scale studies where we're more able to delve more deeply into those factors by asking individual patients, for example.
So it's amazing that such a common condition, such limited participation with eye doctors to look in their eye, and we know so little about it. What were some of the things you wanted to look at? What were the goals or some of the objectives that you thought you might look at to see what's running this number?
Right. We wanted to investigate on a large scale, a nationwide scale, whether some of the factors that fall into the category of social determinants of health could be associated with seeing an eye care practitioner among people with diabetes. And some of these social determinants of health, broadly defined, include the conditions where people are born and live and work and so on, and all these factors that can affect their health and their functioning and their quality of life. So that includes things like housing in neighborhoods, or language or literacy, education and income, racism. All of these can affect people's health outcomes and lead to health disparities and inequities.
So those does seem very important. Now, you said you did an analysis from a nationwide group. What was exactly the group that you investigated this in?
Right. So the data set, or the cohort that we investigated this question in, was the All of Us research program. Now, this is a very unique, large project administered by the National Institutes of Health, and it's building one of the largest biomedical data resources of its kind. And it now includes data from over 500,000 participants across the United States, and it stores many different kinds of health data from a diverse group of participants. Notably, it includes electronic health records, which are collected and harmonized from many different centers to a single standard to facilitate observational research. And it includes a wide range of surveys, which allows participants to self-report on many of those factors that we were speaking of, not just basic demographic information, education, income, and so forth, but there's also surveys that self-report general health, food and housing insecurity, perceptions towards healthcare and healthcare practitioners, various factors related to healthcare access and utilization. Many of these details aren't available in traditional large data sets used for observational health studies. For example, they wouldn't be available in insurance claims data. So we thought that this would be really a great starting point to kind of a nationwide study of these factors. And I'll emphasize that this program really wants to capture an especially diverse population, including groups that are traditionally underrepresented in research, whether that be racial or ethnic minority groups, patients from rural areas, patients from low income or low educational backgrounds, other kinds of underrepresented groups. That's a really big mission of the All of Us program. So combining that with the large scale and the unique kinds of data that it collects, it was a really good starting point for the study.
So if we look at the people in that group that had diabetes, let's just start with the simple number. What percentage actually reported any sort of eye care over the past year?
Right. So we looked at whether patients could self-report on the survey whether they had seen an eye care practitioner in the last 12 months. And in the end, the study cohort we included was about 11,551 patients with diabetes who answered that question. Almost 70% of those patients did self-report yes on that eye care question.
So a little higher than that 50% than I first characterized. Do you have any reason? Was this maybe we're taking better care, the word's getting out there? Or do you think it's just a different cohort and that may explain 70% versus 50%? Let's just hypothesize there.
It's hard to know. It is, of course, a different cohort, a larger cohort from many previous studies. Some of those studies were performed in specific populations that had different kind of demographic makeup. So, that could be a reason why it's a little bit higher here.
And I certainly don't want to imply that 70% is necessarily a good number. I mean, we'd like that to be closer to 100%. But then you said the whole purpose was to look at what some of these social determinants of health might be or other barriers to having seen an eye care provider or not. What did you find?
Well, we did confirm on a large scale that having higher educational level, higher income, having insurance were associated with reporting yes on that eye care question. For education and income, the highest brackets in those groups had actually 50% higher odds of answering yes on that eye care question. And people with insurance had almost twice the odds of answering yes on that eye care question. This is all sort of holding everything else equal, adjusting for other demographic factors like race and gender and so forth. We also kind of looked more deeply at some of the other self-reported factors beyond just the basic sociodemographics. People with food insecurity or housing insecurity were less likely to answer yes on that eye care question.
And to my knowledge, those latter factors had not necessarily been looked at in large cohorts or certainly in national cohorts. Is that correct? This is maybe the first time we've identified this and its association with having an eye care provider visit in the last year.
Yeah, on a large scale, this is one of the, I think, only studies that I'm aware of that reports these factors. Kind of another interesting thing we looked at, and maybe a little bit of a surprise, some of the survey questions we studied had to do with participants' attitudes towards concordance with their doctors or with their healthcare providers. So, for example, some people think it's important for their doctors to understand or share their race or ethnicity or gender or religion or beliefs or, different background aspects. And so one of the questions that participants were asked was, how important is that concordance to you? Or how often have you delayed care or not gone to see a healthcare provider because they were different from you and some of those factors? And participants who thought concordance was somewhat or very important had lower odds of answering yes on that eye care question. And similarly, those who actually reported delaying care because of those factors, some or most of the time had lower odds of answering yes to those questions too. And this was really eye-opening to us.
And very important to follow up on. So some of those factors you mentioned might be associated with one another or might be associated with other factors that could be confounding to what you had. How did you try to address that so far? I know you can never take care of all of potential confounding factors, and I realize this is just to generate some hypotheses of how to go forward and improve on your 70%. But what were some of the main factors you looked at to try to say, is it really, this practitioner concordance, or Is it really some of these other social determinants of health, or could it be other confounding factors?
I think one of the nice strengths of the All of Us set of survey questions is that it really did cover a wide range of social information about patients. And so we were able to do things like adjust for or account for a wide range of factors: age, gender, race, ethnicity, education and income, like we spoke about. We also included factors like employment status, relationship status, married, never married, widow. All of these kind of social factors entered into our analyses as things we tried to hold steady or, hold constant and adjust for. And all of the investigations into some of those deeper social determinants of health, like food insecurity, health insecurity, practitioner concordance, those are all adjusted for those demographic variables as well. And of course, as you mentioned, we can't adjust for everything. We don't know everything about a patient necessarily, but it's at least a start that we can include these factors.
Well, I think that only strengthens the concerns of how important these potential barriers are. And finally, what about the level of retinopathy? For example, someone who's been told, oh, good news, no diabetic retinopathy in your eye, I'd like to see you next year again. That's a little different from someone who you say, oh, this is very serious. You have very advanced changes to the back part of your eye. I need to see it in 3 or 4 months to check on this. Did that somehow influence the answers or the results that you got, or really that's superfluous to what you were investigating?
Well, we know at a baseline the recommendations of our, American Academy of Ophthalmology and various societies is that at a minimum we should be doing annual eye examinations for patients with diabetes, regardless of their diabetes control. And it only goes up from there, as you mentioned. If we have findings, they should be seen, more frequently, even potentially than once a year. So when we did this study, we wanted to look at what might be, considered the minimum amount of eye care recommended for patients with diabetes, which would be annually, and as asked by the survey question. But you bring up a good point, since people with more severe diabetic retinopathy or findings should potentially be seen more frequently, that's potentially an area of future investigation that we could look at. It's a little bit hard to tease out exactly how severe someone's diabetic retinopathy might be based on electronic health records because of a variety of limitations of, the coding or diagnosis codes that we use to identify those patients. There may not always be accuracy in that coding, and we can't tell from records how soon patients were told to follow up. So, for example, if someone's retina specialist told them to come back in 3 months or 4 months, and the patient came back in 6 months, we wouldn't be able to tell that there was a degree of lapse in care there because the recommended follow-up interval is not something that's routinely captured in electronic health records.
Yeah, very important. So, what would you tell our colleagues in internal medicine or endocrinologists who take care of diabetes by what you found? And what should we tell our ophthalmologists based on this?
The basic message of we need to have these patients see their eye care provider and get an annual eye exam, it doesn't change, right? Even though we found 70% of patients answered yes on the question, as you say, the guidelines are really 100%. Everyone should have those eye exams. But, we have information on who we should target to help get those eye examinations. We should focus on income, education, health insurance. These are the factors that help patients get their eye exams. We should help people with food and housing insecurity. Maybe we should improve workforce diversity if, patient and provider concordance is really an important factor in healthcare utilization and eye care utilization. That could be something to think about for improving healthcare on a large scale.
Yeah, those are some wonderful next steps. And I hope you and your colleagues or others in the nation and the world can look into that and maybe show us when they attacked that. That number did go from 70, 80, 90%, even For the people that maybe come every other year, we want them to know, and especially if they have retinopathy, perhaps to be seeing them every year. Well, I just want to thank you so much. For our listeners, I've been speaking with Dr. Sophia Wang at Stanford University about some social determinants of health and perceived barriers to care in diabetic retinopathy screening or monitoring that they did with the All of Us cohort. And we've just learned so much, and we have so much more to do. Sophia, thank you for joining us.
Thank you so much, Neil. I really enjoyed this conversation.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.